Hello, everyone. My name is Kathy Flynn, and I am the National Senior Director of Engagement for the American Liver Foundation. Welcome to today's webinar, Ask the Experts, Frequently Asked Questions About Fatty Liver Disease. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. Since 1976, we have provided a voice for patients with liver disease and their families through education, support, research, and advocacy. Today's Ask the Expert featured speakers are Dr. Mary Flynn and Dr. Preeti Reshamwala, who will be introduced shortly. Thank you to Dr. Flynn and Dr. Reshamwala for sharing their time and expertise on today's webinar. And thank you to Bristol Myers Squibb and Intercept Pharmaceuticals for generously supporting this educational program. Joining us today is my colleague, Lindsay Ventura, the National Manager of Outreach and Education. Lindsay will be assisting us behind the scenes and will introduce our expert speakers shortly. But first, Parisa Sanandaji, the Director of Patient Advocacy for Intercept Pharmaceuticals, will share a few words.
So thank you to Kathy and to Lindsay and to the American Liver Foundation. Intercept is proud to support the American Liver Foundation and also share in our goals and mission of helping those who are living with progressive non-viral liver diseases. And so thank you for the opportunity and best of luck in this program. Thanks.
Hello, everyone. This is Lindsay Ventura, National Manager of Outreach and Education for the American Liver Foundation. I wanted to quickly review a little bit of housekeeping before we get going in today's program. On the upper right-hand part of your screen, you should see a dialog box. If you do not see it, there's an orange arrow you can use to expand the window. From here, you may ask questions by typing them into this box. Please feel free to ask questions at any time. We will follow up with any questions asked during the program following this webinar. In this box, you will also see a handout section. We've created a helpful toolkit which provides resources to support and educate patients as they continue their journey through NAFLD and or NASH. Please download this toolkit during this webinar. As my colleague Kathy Flynn mentioned, our speakers today will be answering frequently asked questions about fatty liver disease. These questions were submitted by members of the American Liver Foundation's NASH Facebook support group, as well as questions they regularly receive in clinic. It is my pleasure to introduce our first speaker, Dr. Mary Flynn. Originally from Massachusetts, Dr. Flynn joined the Emory Transplant Center in 2018 and serves as Assistant Professor of Medicine at the Emory University School of Medicine. She earned her medical degree from Boston University and completed her residency at the University of Virginia Medical Center. Dr. Flynn then completed clinical fellowships in both gastroenterology and transplant hepatology at the Emory University School of Medicine and joined the practice following completion. Dr. Flynn's clinical interests include non-alcoholic fatty liver disease, alcohol-related liver disease, end-stage liver disease, and acute liver failure. She also has a particular interest in quality improvement. Dr. Flynn is an active member of the American Association for the Study of Liver Diseases, the American College of Gastroenterology, and the American College of Physicians. Thank you to Dr. Flynn for taking time out of her schedule today to take part in this webinar.
One of the most common questions that we get in liver clinic is, what is non-alcoholic fatty liver disease? Fatty liver is just that. It's fat deposit in the liver. Non-alcoholic fatty liver disease, or NAFLD, means that someone has fat deposit, which is also called steatosis, in the liver that's not caused by something else. So NAFLD is not the only cause of steatosis in the liver. For example, alcohol, certain medications, or hepatitis viruses are just a few examples of other things that can also cause this. And these other causes have to be ruled out before we can determine whether someone has NAFLD. NAFLD is a very common condition. About 25% of people across the world have NAFLD, so that's 1 in 4 people. It can be associated with inflammation in the liver, and it can be associated with what's called fibrosis, or scarring in the liver. I emphasize can because the presence of steatosis alone does not necessarily mean that you have inflammation or scarring in your liver. And NAFLD really includes the entire spectrum of fatty liver disease. So within NAFLD, there are two different but very closely related processes. So within it, you can have what's called NAFLD, and that's non-alcoholic fatty liver, or you may have what's called NASH, and that's non-alcoholic steatohepatitis. And really the main difference here is that in NAFLD, you have steatosis, or that fat deposit, but you do not have inflammation. Whereas in NASH, there is significant inflammation and possibly even scarring. You may hear people use these interchangeably as if they're one and the same. And while they are closely related and fall on a spectrum, they are different from each other, and it's important to understand why. Ultimately, it's the inflammation and/or scarring that can lead to liver damage. And so NASH, which by definition has the presence of inflammation, is the more severe form of NAFLD. And we'll talk about this a bit more as we work through these questions. Another common question we often get is, how would I know if I had NAFLD? And this can be quite tricky because most people with NAFLD actually do not have symptoms. Some do have a discomfort in the upper right part of the abdomen, and we're not entirely sure why that is, or some might have fatigue, but this is really challenging because fatigue is one of those that can be seen in a number of different problems. So really, more often than not, people are not going to have any symptoms related to this. And it usually comes into attention because either blood tests show elevated liver numbers, or radiology studies of the abdomen, such as an ultrasound, MRI, or CAT scan, show findings of steatosis, which again is that fat deposit in the liver. And although it's very typical for people to have what we would classify as mild to moderate elevation in their liver numbers, these can also be normal. But imaging findings, again, those that we see on the ultrasound, MRI, or CAT scan, and blood tests together are often enough to make this diagnosis. And a liver biopsy may have a role when we're trying to answer different questions, but it's really rarely needed to diagnose NAFLD. So again, this diagnosis is not always obvious to a patient. And as I mentioned, it's most often brought to light by either abnormal liver numbers or findings of steatosis on an imaging study. And as providers, when we see abnormal liver numbers and we suspect NAFLD, we'll usually next look for changes of that steatosis on a radiology study. And as we discussed in the prior question, not all steatosis is caused by NAFLD. And so your provider will need to do tests to rule out other causes before ultimately making the diagnosis of NAFLD. It's also important to keep in mind that these do not necessarily tell you whether there's underlying scarring or damage to the liver. We do have ways to look for this. So we can do this through a combination of blood tests, very specific imaging tools such as elastography, or what's called FibroScan, which is what we typically use at our center, and sometimes even liver biopsy. And there really isn't one specific way to do this, and oftentimes it's really individualized, meaning we take each patient's situation into consideration. And so this is something that really should be a conversation with your provider. Another important question we often get is, well, really, why should I care if I have NAFLD? And ultimately, the reason that we as providers care about non-alcoholic fatty liver disease is because it can progress to cause scarring, which is also called fibrosis in the liver, which over time can lead to more advanced liver disease or cirrhosis. In fact, NASH is one of the most common reasons for needing a liver transplant in the United States. This progression or worsening of a disease occurs along a spectrum. You can have what's called simple steatosis, which is fat deposit in the liver. This can lead to steatohepatitis, which is the presence of inflammation in the liver. That can ultimately cause fibrosis or scarring, and that can build over time and lead to cirrhosis, which is the advanced form of liver disease. Now, the risk that someone will have this disease progression has been looked at in a number of studies, and those results have varied quite a bit. And so we really don't know the exact risk, but when we look at all of those studies together, we believe about 30% of patients will progress, meaning that their liver disease will get worse along that spectrum. About 50% will maintain, so their liver won't get worse and it won't get better. And the remaining about 20% or so will actually show improvement. So how do we really know who's more likely to progress? In general, those with NASH are at higher risk of developing more advanced scarring or more severe disease compared with those with NAFLD. And that risk could be as high as 2.5 times higher. In addition to that, those with NASH could happen in a much shorter time span, so about 4.5 years compared to 13 years in those who don't have NASH. In addition to the presence of NASH, there are other risk factors that can help us predict the risk of developing significant scarring in the liver. These include alcohol use, being overweight or a BMI over 28, age over 50, and persistent or on multiple different checks, elevation in liver numbers. We call AST and ALT above a certain range. And so knowing that there's a risk of causing liver damage, it's important for us to identify those who have NAFLD. And once we've identified that, we can look for whether liver damage is present. In other words, try to figure out if there's severe disease and focus on ways to intervene with the goal of preventing any damage or additional damage. Why did I get fatty liver? And this is an area that we're really still learning about, but what we do know is that there are several medical problems that are associated with NAFLD. And these are considered risk factors for the development of NAFLD. Common medical problems that we know can lead to NAFLD include obesity, diabetes, what's called dyslipidemia, which is elevated cholesterol and/or triglycerides, and metabolic syndrome. Metabolic syndrome is made up of several criteria that I've displayed on the screen for you. In addition to those conditions, there are several others that are believed to have an association, but the relationship is really not as clear. And I've listed those on the right. And as you look through that list, these are really quite rare. And again, we're still trying to understand a potential relationship. And so the ones to really focus on are those in the category of a clear association. So as you can see, there are a number of potential risk factors for NAFLD. And you can hopefully also see that NAFLD is heavily influenced by lifestyle, meaning the diet and exercise habits that we have. Of these risk factors, we found that obesity is the most common risk factor for the development of NAFLD. And greater than 95% of people who have severe obesity will have NAFLD. But it's really the entire spectrum of obesity. So it's not just severe obesity that's associated with it. Similarly, type 2 diabetes is very common in about 30%, and it may even be as high as 70% of people with type 2 diabetes will have NAFLD. And then finally, dyslipidemia is also quite common, and we're not sure of the exact numbers for that. It's important to realize, though, that this is looking at NAFLD. And as I talked about in the first question, NAFLD includes two different entities, and that's NAFLD and NASH. The number of people with NASH will be lower than the numbers I've quoted, but it's still fairly significant, and we think probably about 25% of people with obesity and type 2 diabetes will have NASH. Now, you might be wondering why some people with these risk factors go on to develop NAFLD while others do not. Or you may also be wondering why some people may not have any of these risk factors but still develop NAFLD. And you'd be right for wondering about this because NAFLD affects different people in different ways. It varies across sex, it varies across age, and it varies across ethnicity. And importantly, a lot of this ethnic or worldwide difference is probably or may be driven by a genetic variation, with some having a genetic predisposition, meaning that some people are more likely to develop these changes in the liver than others. And this is what we would call a non-modifiable risk factor, in that we can't change our genetic makeup. Instead, what we really need to focus on are those that we can, and we'll spend some more time talking about this in the upcoming questions.
Thank you, Dr. Flynn, for answering those questions. It's now my pleasure to introduce our next speaker, Dr. Preeti Reshamwala. Dr. Preeti Reshamwala is a board-certified gastroenterologist and transplant hepatologist with 10 years of experience. She is fellowship trained from the University of Maryland Medical Center in Baltimore, Maryland. She also received advanced training in clinical investigative research from the liver disease branches from NIDDK, National Institutes of Health in Bethesda, Maryland. She previously served as the medical director for transplant hepatology at the University of Maryland Medical Center prior to joining the faculty practice at the Emory Transplant Center. Dr. Reshamwala has recently rejoined us from Southern California Liver Centers in San Diego, California, where she held the position of associate director. She has extensive experience in clinical trials. Dr. Reshamwala's current research interests include management and new therapies for fatty liver disease and viral hepatitis. You will also see that she is the director of the Fatty Liver Clinic at Emory University School of Medicine.
How and when should I get tested? The American Association for the Study of Liver Diseases, our National Liver Society, does not endorse screening for fatty liver disease for the general population. This may seem unusual given how widespread the condition is. However, as Dr. Flynn pointed out, most people do not get serious or advanced liver disease from fatty liver. Additionally, at this time, we do not have any therapeutics for the treatment of fatty liver disease. However, we, as healthcare providers and partners in your care, should have a low threshold to test those patients who have diabetes, those patients with obesity, specifically a body mass index greater than 30, and patients who have high cholesterol. We would screen these patients by checking liver tests and routine blood work. We then use these liver tests to calculate risk scores, which are called non-invasive tests, to help guide if any further testing, including possibly an ultrasound or FibroScan test, is needed. If you have a family history of fatty liver disease or any family member who may have had liver disease of unknown cause, it may also be prudent to get liver blood tests. This is a discussion you should have with your provider. However, it is important to recognize that there are currently no FDA-approved medications for the treatment of fatty liver disease. Therefore, lifestyle changes with diet and exercise are most likely to improve fatty liver and will be recommended regardless of your test results. And finally, if you have ever had unexplained elevations in your liver tests, it would be important to speak to your healthcare provider to determine if testing for fatty liver is appropriate for your situation. What can I do to stop non-alcoholic fatty liver disease from getting worse? Currently, there are no pharmacologic therapies for the treatment of fatty liver. There is at least one drug that is going through FDA evaluation and several others in clinical trial. However, as of today, the best advice to improve inflammation associated with fatty liver is to lose 5% of your total body weight. Weight loss of 7 to 10% of your total body weight has been shown to improve both inflammation and the scarring associated with fatty liver disease, which is the key to halting this process. One very simple but important thing to do is to look critically at your medication list with your healthcare provider. First of all, you want to make sure that the medications you are taking are weight neutral. Several medications, including common antidepressants, psychiatric medications, blood pressure medications, and many other classes of medications can predispose you to weight gain. So if these medications have been prescribed to you, it may be prudent to have a discussion with your provider about alternative options. Remember, do not stop these medications without speaking to your provider. Also, there are some diabetic medications that are associated with weight loss. And if indicated for your situation, you should speak with your provider about choosing those medications to manage your diabetes to get the additional benefit of weight loss. Keep in mind that tight control of your blood glucose and cholesterol can greatly improve your chances of decreasing ongoing liver inflammation from fatty liver disease. Several medications have been evaluated over the past 10 to 15 years for the treatment of fatty liver disease. Most, unfortunately, have not been proven to have any benefit. However, vitamin E may be helpful to improve inflammation in non-diabetic female patients. But much is unknown about how long this effect lasts. There's also some concern for cardiovascular disease and prostate disease in patients taking vitamin E long-term. So the decision to take vitamin E should be made in collaboration with your physician. The diabetic medication pioglitazone may also be helpful in improving fatty liver. However, this medication tends to cause some weight gain, so the overall efficacy of this is unclear. There are also some important long-term side effects to consider with this drug. Finally, you may want to consider a clinical trial. Clinical trials are studies looking at newly developed medications in a rigorous scientific manner to determine if they are useful for the management of fatty liver disease. Please speak with your specialist to see if a trial is available in your area that you qualify for and that you are interested in. What diet is best for fatty liver? This is the most common question I'm asked by patients and probably the most frustrating from a patient perspective. If you go to the internet and Google this question, you will notice that there's no one specific diet that is recommended to all patients with fatty liver disease. That is because dietary choices should be tailored to each person's individual needs. For example, a diabetic patient must follow a carbohydrate-controlled, calorie-restricted diet. And for example, a patient with high cholesterol may need to concentrate on diets lower in saturated fats and animal protein, along with a caloric restriction. In general, a Mediterranean diet with lower carbohydrate intake is generally a good place to start and is the most widely scientifically studied diet associated with long-term sustained weight loss. Again, calorie restriction is the key here. There are methods available to estimate your baseline calorie intake needed to maintain your current weight. Then you can adjust this calorie intake downward to promote an overall calorie reduction, which will hopefully lead to weight loss. It is important to have realistic goals and to understand that there may be ups and downs in this process. However, long-term commitment to nutrition is paramount for maintaining good liver health. I am skeptical and often warn my patients away from fad diets. For example, the keto diet can certainly help patients lose weight and lose weight quickly, but it may also cause serious low blood sugar in diabetic patients. Additionally, it is difficult as a healthcare provider to stand behind a diet that promotes the intake of such large amounts of fats and saturated fats. There are many other fad diets out there, but as you likely know, none have stood the test of time and are generally not supported by the medical community. So in summary, there is no one-size-fits-all diet for fatty liver disease, but a heart-healthy, calorie-restricted diet is a good place to start to help you achieve your goals of weight control. I have tried diet and exercise, but cannot lose weight. What are my options? This is the million-dollar question. Keep in mind, there's no one correct answer or one easy answer. Instead, I'd like to give you some suggestions that will help guide your choices in your journey to live a healthy lifestyle. Data shows that we are notoriously inaccurate in our recollection of dietary intake. The data also shows that tracking every bite of food intake allows for overall more recognition of how and when calories are being consumed. You can do this by keeping a traditional food journal. However, tracking apps are also a great way to do this and have been shown to be associated with a greater weight loss than those who diet alone without tracking. It's important to be honest and accurate and to learn and to understand portion sizes. For example, if you eat 8 crackers and the serving size is 4 crackers, it's important to document that you had 2 serving sizes of this food. In fact, taking this information to a nutritionist will have you one step ahead of the game when working with the dietitian on meal planning. I am also often asked about how exercise helps fatty liver. Well, exercise alone has not been shown to decrease weight without a simultaneous plan to decrease calorie intake. Aerobic exercise is initially most important to burn calories. A slow walk without increasing your heart rate will not provide the results that you're looking for. There must be moderate intensity aerobic exercise for 40 to 60 minutes, 4 times a week. This may include running, jogging, bicycling, swimming, or similar activities where your heart rate is consistently in a weight loss zone. All exercise routines should be cleared with your physician, especially if you have cardiovascular or renal disease. Often a weight loss plateau happens several weeks or months into this process. Adding resistance exercises at this point can jumpstart some additional weight loss. Resistance exercises are also important for postmenopausal women to aid in preventing bone loss. Another resource you can look into are medical bariatric centers. Bariatric centers are a useful resource for patients who are frustrated about weight loss despite doing all the things that we have talked about. I would suggest that you find a comprehensive weight loss center with a multidisciplinary team of specialists who work with you for a common goal of weight loss through a combination of approaches. I caution against finding a clinic that will prescribe you a medication with no follow-up or other supportive services. Nutritionists associated with bariatric centers can supervise low-calorie diets and even meal replacement plans. Very low-calorie diets, those with generally less than 800 kilocalories per day, should only be performed under the supervision of a team of specialists. Mental health also plays a big role in our ability to lose weight and to keep it off. Many of us are emotional eaters. I think this term will resonate with many out there, especially during these stressful COVID times and stressful socio-political times. Making sure you are getting enough sleep will help ensure a more even regulation of certain hormones that make people hold on to weight. And dealing with stress in a productive way, perhaps through therapy, can be very eye-opening for those who are emotional eaters. For patients with more advanced underlying mental health disorders, there are mental health providers who specialize in compulsive eating and anxiety disorders. But please remember to not minimize your health during your weight loss process. And finally, weight loss medications are a wonderful addition to help people who are committed to doing all of these things that we have talked about. However, these medications are ineffective without all of the other effort that we have mentioned. And these medications can have significant side effects. So it is important that a provider with experience with these medications is supervising your care. At the Fatty Liver Clinic at Emory Health, we provide these options while simultaneously managing your liver disease. And remember, a yo-yo weight loss and weight gain is actually worse for the liver, so it is best to refrain from trying to find a quick fix.
On behalf of the American Liver Foundation, I thank you for viewing today's webinar. We hope you enjoy the American Liver Foundation's virtual toolkit that accompanies this educational program. Lastly, a special thanks to Dr. Mary Flynn and Dr. Preeti Reshamwala for sharing their expertise and time with us today. And again, thank you to Bristol Myers Squibb and Intercept Pharmaceuticals for their philanthropic support of this educational program. Thank you, everyone.